Thank you everyone for being here today. My name is Olivia Piconis, and I would like to talk with you about disordered eating during pregnancy. If this is not something that is affecting you now or will in the future, it may be something that you need to support a family member through. I want to start by giving you this statistic from our community of Denver, Colorado. In 2010, 43% of expecting mothers were gaining more than the recommended amount of weight during pregnancy, and 22% were not gaining enough. Only 1/3 of expecting mothers gained the recommended weight, which is healthiest for mother and baby. This number is surprisingly low to me. Before we can talk about the implications of not gaining enough weight during pregnancy, I feel we must establish what has been determined to be the recommended pregnancy weight gain. As you see in this table, the amount of weight you should gain during pregnancy is dependent on your height and weight before pregnancy. We know that BMI does not include muscle and body fat percentage, but this is a rough guide for you to work with. Essentially, the heavier you are, the more your body can pull from energy reserves, so the less weight you need to gain. What are the implications for the 22% of women in Denver who did not gain the recommended weight during pregnancy? The human body prioritizes mothers' nutritional needs over the needs of the growing fetus. For this reason, low weight during pregnancy is associated with a wide range of poor fetal outcomes, including infant death and congenital abnormalities. Infants are often born proportionately small for gestational age, which means they are born with an overall reduced number of cells in organs and tissues with poor catch-up growth. This may cause impaired development physically and mentally. Additionally, infants that are born proportionally small for gestational age and that gain weight quickly during the catch-up phase of their growth may have increased risk for developing obesity, hypertension, and type 2 diabetes later in life. There is a further distinction we need to make between someone who consistently doesn't gain enough weight during pregnancy and someone that gains weight but then loses it, especially in the third trimester. This puts the infant at risk for being disproportionately small for gestational age. Complications include infants born with smaller than normal organ size, risk of developing any of the hypo conditions, and the increased risk of developing a chronic disease later in life, such as heart disease, hypertension, and type 2 diabetes. So now we have to ask the question, why might someone not gain enough weight or lose weight during pregnancy? There are a variety of reasons. Famine or lack of access to food for physical or financial reasons, appetite loss, and chronic morning sickness are some reasons weight gain may be difficult. Lastly, disordered eating may be a cause of low weight gain or weight loss during pregnancy. One small study found 11% of postpartum women who suffered, One small study found 11% of postpartum women suffered from some type of eating disorder. It's difficult to get a reliable statistic because disordered eating can mean many things and is usually accompanied with shame and guilt. This means not all women will confide in their physician or seek support. It's important to establish the effect that getting pregnant may have on someone who is suffering from a pre-existing disorder or even is just struggling with her body image, but does not have a diagnosed disorder. A recent community-based prospective study of 12,254 women with a history of an eating disorder, inactive eating disorder, obesity, or no eating disorder reported that women with an eating disorder generally improved throughout pregnancy due to their desire to protect their baby. However, this group of women still reported continuing concern and anxiety about their weight, dieted more often, used more laxatives, exercised more, and practiced more self-induced vomiting than other groups of pregnant women. This is a list of complications pregnant women with eating disorders should be aware of: spontaneous abortion, hypertension, and difficult deliveries. Increased rates of C-section and postpartum depression were also very common. A retrospective case control study of 94 women with eating disorders found that a third of them developed postnatal depression, as compared with 3 to 12% in the general population. Now we'll talk specifically about individual eating disorders. Anorexia nervosa is a severe food restriction and intense exercise as a measure to be thin or out of fear of becoming fat. Sometimes it can be felt as a measure of control. It's most common in women of childbearing age, but many of these women are infertile because it interferes with the hormones regulating their menstrual cycle. Many women don't get their period, but it is actually still possible to become pregnant. Bulimia nervosa is the regular binging on large amount of foods, followed by measures to prevent weight gain, including vomiting, laxative use, enemas, fasting, or excessive exercise. Bulimia is 10 times more common than anorexia and could be more prevalent than we know because it is not as physically apparent as anorexia. It can be seen in individuals of varying weights and commonly goes into remission and resurfaces at later times. This is a list of advice we can give to support people with eating disorders during pregnancy. Obviously, resolving an eating disorder before pregnancy may reduce negative outcomes, but it isn't very good advice to give someone who is already pregnant. It is important to establish and maintain a good relationship with a physician as early in the pregnancy as possible, and disclose information about past and current issues and feelings around weight. The physician should discuss ideal weight gain and impact on the baby. There is a great resource available on the USDA's Choose My Plate website that allows you to input your height and pre-pregnancy weight to calculate how much weight you should expect to gain and when. It can also be helpful to discuss what changes in size to expect and what they mean. Discuss cravings, eating patterns, exercise, and habits. Create a form of reinforcement to reward yourself when weight gain goals are met. This can be a way to include a friend or family member to keep accountability between doctor visits. Physicians should be able to make referrals for specialized therapy options if needed. Nutritional recommendations are similar for all pregnant women, and individual recommendations are based on trimester, physical activity, and weight before pregnancy. Again, individualized nutritional recommendations and meal plans are available at the USDA Choose My Plate website. Important details to focus on, especially for someone who struggles with food, is the importance of regular structured meals. If it's part of your daily routine, there will be less of an excuse to forget a meal. Maintaining a balanced diet by incorporating carbohydrates, fats, and protein is very important. Many times, women are afraid of carbs and fat, but it's recommended pregnant women get 33% of their daily calories from fat and 50 to 60% from carbohydrates. Coconut oil and nuts can be good sources of fat and are easy to add to oatmeal in the morning for a balanced breakfast. Focus on incorporating nutritionally dense foods like fruits, vegetables, and whole grains. This is an example of recommendations from Choose My Plate. It gives a good idea how someone should increase their portion sizes as they enter their second and third trimesters. I wouldn't necessarily recommend drinking 3 cups of milk every day, but you can include cheese, yogurt, or dairy substitutions. This can be a very helpful format for someone when making their dietary goals. The last eating disorder I wanted to discuss is one that is seen all over the world and actually affects an estimated 50% of pregnant women in the southern United States. Pica is the desire to eat non-food items. ice and freezer frost, laundry or cornstarch, baking soda, baking powder, paint, clay, dirt, burnt matches, stones, charcoal, mothballs, toothpaste, soap, sand, plaster, coffee grounds, and even cigarette ashes are all substances pregnant women have craved and consumed. Some cultures believe that this is the body's way of getting something it needs, but there can be dangerous consequences. Complications range depending on what the ingested substance is. Frequently consumed ice is associated with iron deficiency anemia. Ingesting starch may complicate control of gestational diabetes. Eating paint chips may cause lead poisoning, and eating dirt may cause a parasitic infection. Other complications include intestinal obstruction and a vitamin or mineral deficiency caused by blocked absorption. If this happens to you, be sure to inform your healthcare practitioner immediately. They will check your iron status and discuss your vitamin and mineral intake and potential deficiencies. It can be helpful to choose something like sugarless gum to chew on when having cravings, and inform close friends and family to help monitor you. That's all I have prepared for you. I hope you found this information useful, and please let me know if you have any questions. And lastly, this is my list of references that I used.